So hello and good afternoon to everybody. Good morning to our American friends, or maybe it's still night for them. And to Assalamu alaikum. And I'm really pleased to be starting our breast cancer sessions for the SKM Symposium 2021. The first session, we've got two superb surgeons who really don't need any introduction, but they will be talking to you about latest aspects about surgical oncology of breast cancer. And then we have two medical oncologists who will be talking about triple negative breast cancer and brain cancer metastasis. So and with me, my co-chair is Dr. Zulkarnain Chaudhary. He's a
Hello.
surgical, he does a lot of breast surgery, and we worked together for several years now. So Zulkarnain is going to be starting the surgical talks and introducing our first speaker, Dr. Laszlo Romix.
Good morning, ladies and gentlemen. Assalamu alaikum and welcome to the session. In this session, we will shed light on the latest research and recommendations which are related to the management of breast cancer. Our speakers today are some of the leading names in their fields. We are honored to welcome our first speaker, Mr. Laszlo Romich, who is a PhD and FRCS, and he has a very long introduction. I will introduce him. He is consultant oncoplastic and breast surgeon. He is an honorary clinical senior lecturer at the University of Glasgow, Gartnavel General Hospital, Glasgow, Queen's Elizabeth University Hospital, Glasgow, Department of Academic Surgery, University of Glasgow. He is also a panel member for the United Kingdom of the Oncoplastic Breast Consortium. He is a co-lead Surgical QA Scottish Breast Screening Program. He's a member of Academic and Research Committee of the Association of Breast Surgery. He's a clinical advisor for Association of Breast Surgery at NHS BSP. He is a screening, and he is also a member of a screening committee and a chair of Academic and Research Committee of the West of Scotland Managed Cancer Network. So Mr. Romich will talk about effect of post-operative complications on survival and recurrence after breast cancer surgery. So over to Mr. Laszlo Romich.
Good afternoon, Dr. Siddiqui, Dr. Chaudhary, Dr. Parvaz, and all participants of the symposium. I'm Laszlo Romich. I'm an oncoplastic breast surgeon in Glasgow, in the UK. Thank you very much to the organizing committee for inviting me to speak again on the Shaukat Khanum Cancer Symposium. It is always a pleasure to participate on this prestigious meeting, so I'm grateful for allowing time for me to speak on the effect of postoperative complications on survival and recurrence after breast cancer surgery. Breast cancer is the most common cancer in the UK and accounts for 15% of all cancer cases. Ongoing deaths due to recurrence have raised the need for deeper understanding of factors relating to metastasis and disease spread. Therefore, we performed a systematic review on the impact of complications on long-term outcomes for patients with primary invasive operable breast cancer. In 2008, de Michel et al. Reviewed the effects of surgery on tumor growth, and they suggested that surgery played a role in tumor homeostasis, dormancy, and surgery-driven enhancement of metastasis development. This finding has its roots in a work published more than a century earlier in 1905 by Ehrlich and Poland, which paved the way for our understanding how surgery may interfere with this homeostatic process, in fact, accelerating disease progression. It is clear that factors related to wound healing after surgery, particularly as they utilize similar pathways of angiogenesis and control of infection, may provide evidence of the role of postoperative inflammation in the natural history of cancer. When observing the immunological landscape surrounding cancer's natural history, cytokines such as TNF-alpha, IL-6, PDHF, and VEGF have all been implicated as tumorigenic and tumor-promoting agents. On the cellular level, the current understanding is that within the T helper communities, Th1 adaptive immunity plays a role in carcinogenesis, while Th2 immunity may have a greater role in tumor progression. Significant evidence of the effect of surgical complications has been described for colorectal cancer, and evidence now exists for the role of postoperative complications in determining outcomes for head and neck cancer, esophageal cancer, gastric cancer, and lung cancer. For breast cancer, initial evidence suggests that there may be a link between postoperative complication and recurrence risk. In 2018, Beecher et al. Suggested that wound complications affected outcomes for breast cancer patients, and single-center retrospective evidence exists to support this. However, there are still a number of published reports suggesting that postoperative complications do not always negatively affect prognosis, leading to the need for objective comparison of the evidence. This review seeks to identify, evaluate, and compare the current evidence for patients with primary invasive operable breast cancer who suffer postoperative complications and establish whether these affect prognosis and survival. The study has been published in the Critical Reviews in Oncology and Hematology journal in November 2020, and you can find the relevant full details in the published paper. Here, a short summary is given. An online literature search using Embase, PubMed, and Cochrane Library was performed in December 2019 to January 2020 to assess the role of postoperative complication on breast cancer prognosis. The final search terms were breast neoplasm, breast surgery, mammoplasty, postoperative complication, fever, necrosis, infection, inflammation, prognosis, systemic recurrence, treatment outcome, mortality, neoplasm metastasis, neoplasm recurrence, and survival. Studies dedicated to metastatic breast cancer at diagnosis or exclusively to carcinoma in situ were excluded. Eligible studies were evaluated using the stroke checklist to assess quality. Data collected from studies were year of publication, stage of disease, size and age of population, inclusion and exclusion criteria, the use of adjuvant therapy, as well as definition of complications and prognostic indicators. Prognostic measures such as disease-free survival, total, local, regional, systemic recurrence rates, as well as risk factors for postoperative complications were collected for comparison. Data analysis using Review Manager version 5.3 was used to perform meta-analysis of recurrence and survival. Hazard ratios for each outcome from each study were combined using a random effects model to account for heterogeneity. Only studies that perform multivariate analysis were included. Literature search yielded 9,899 manuscripts. After excluding animal studies, non-English manuscripts, and duplicates, 9,874 manuscripts titles were screened for relevance. 46 studies were evaluated using full text for eligibility according to criteria, and the final 10 papers were included in the final review. There was a total of 37,657 patients in the 10 studies. The largest study by Pedersen et al., including 30,711 patients, whilst the smallest by Abdullah et al. Included 107 patients. Patients were diagnosed from 1985 to 2017. Median follow-up was cited in 8 studies, ranging from 18 months to 229 months. All studies were retrospective cohort studies. 2 studies were based on nationwide database entry, while the remaining studies were single-center. 6 papers included stage 1 to 3 disease, 2 papers included stage 4 disease, while 2 included early stage disease, stage 1 to 2, of which 1 excluded nodal disease. Tumor size was described in 4 studies. Hormone receptor status was described in 6 studies, while HER2 status was only addressed in 3 studies, of which 2 of these defining proportion of cases with triple-negative cancers. Indicato et al. Included only patients who underwent breast conservation surgery, while 4 studies examined patients receiving either breast conservation surgery or mastectomy, of which study by Murthy et al. Also compared immediate versus no reconstruction for mastectomy patients. 5 studies assessing patients with mastectomy only, O'Brien et al. Compared immediate versus no reconstruction, whilst the remaining studies only observed patients undergoing immediate reconstruction. The type of reconstruction varied, but implant-based reconstructions were dominating across the 4 studies, which included autologous reconstruction as well. However, one study, Mosa et al., included implant-based reconstructions only. 6 studies included patients who underwent neoadjuvant chemotherapy, while the remaining 4 studies did not clarify their inclusion or exclusion. Overall rates of complication varied greatly amongst the studies, from 2 to 5% in the context of a single measured complication, which was reoperation for postoperative bleeding, up to 26% in the context of a single measured postoperative fever in 7 days following surgery. This variation can be explained by varying definitions of complications across the studies. The most commonly observed and recorded complications were infection in 8 studies, hematoma in 6 studies, and skin necrosis in other 6 studies. 5 studies were able to identify a relationship between complication and recurrence. Murthy et al. Described a rate of wound complications of 9% when measuring from surgery to complication of adjuvant chemotherapy or radiotherapy. On univariate and multivariate analysis, wound complication remained an indicator of increased risk of recurrence and 5-year recurrence-free survival. In the latter, the effect was exacerbated for patients with poorer NPI scores. Beecher et al. Reported rates of complications of 23.1% with 19.2% of total patients being found to have infection in the 30 days following surgery. On univariate and multivariate analysis, wound complication and then infection both remained risk factors for recurrence. An exacerbation of effect for patients with poorer NPI scores was seen too. The Glass et al. Suggested that overall survival with a median follow-up of 86 months was worse in patients with complications, although the effect was lost on multivariate analysis when adjusted for frailty and comorbidity indicators. Yan et al. Described postoperative temperature above 38 degrees Celsius in 26% of their cohort in the 7 days post-surgery, and suggested that relapsed events were more common in patients with pyrexia, although this association was lost when adjusted for hormone receptor and HER2 status. Indicato et al. Described the rate of postoperative infection in the 3 months following surgery to be 7.7% and reported an increased risk of local recurrence on multivariate analysis. Meta-analysis of 2 studies by Murthy and Beecher, including almost 1,300 patients, in which they reported the impact of complication on 5-year recurrence-free survival, suggest a significant effect of complication on 5-year recurrence-free survival. However, Pedersen et al. Was not able to demonstrate an effect of reoperation for bleeding in the first 14 days postoperatively on recurrence. Abdullah et al. Examined surgical site infection and was unable to suggest a link to either recurrence or survival. Moza et al. Did not demonstrate any relation between complication and locoregional or systemic recurrence after a mean follow-up of 40 months. Meta-analysis of 3 studies by Pedersen, Murthy, and Beecher et al., including just over 32,000 patients in which they reported the impact of complication on recurrence, failed to show a significant effect of complication on risk of recurrence. Let's see the complications individually, whether they were associated with recurrence. These were local infection, systemic infection, persistent wound discharge, hematoma and reoperation for bleeding, skin necrosis, implant removal and implant-related problems, pyrexia, wound dehiscence, readmission and need for revisional surgery, seroma, and anemia, delirium, or cardiovascular thromboembolic disease. Infection varied in definition, such as infection requiring intravenous antibiotics, or any evidence of erythema, tenderness of worms, or some authors use the CDC definition for breast infection, or some defined as drainage of pus from the wound. Rates of infection varied between 4.5 to 19.2%. As mentioned previously, Beecher et al. Found that wound complication increased risk of recurrence and reduced 5-year recurrence-free survival. And the Glass et al. Demonstrated that the rate of systemic infection reduced 5-year relative and overall survival. Hematoma formation rates varied between 2 and 4%. 3 studies identified hematoma as a potential complication responsible for increased risk of recurrence. In these 3 studies, hematoma was amalgamated into complications as a group. They reported to affect recurrence and recurrence risk and 5-year recurrence-free survival. There were 2 studies who assessed hematoma formation, but they were unable to demonstrate this effect. Skin necrosis rates were reported in 5 studies and varied from 2.7% to 10%. When amalgamated into complications, this was found to affect recurrence rate and overall 5-year systemic recurrence-free survival by Beecher et al. In the remaining 4 studies, which expressly classified skin necrosis or flap necrosis as a complication, no direct effect was identified on recurrence or survival. Reconstructive surgery was applied in 5 studies. Rates of implant loss varied from 3 to 15%, but none of these studies reported a significant effect of complication on rates of recurrence or survival. One study exclusively assessed the relationship between pyrexia and recurrence of breast cancer with a single measure of over 38 degrees Celsius in the first 7 days following surgery. The postoperative fever, however, was reported to be associated with reduced 5-year relapse-free survival, although this association was lost when adjusted for hormone receptor and HER2 status. Wound dehiscence was specifically classed as a complication in 4 studies. Rates of wound dehiscence varied between 1.2% to 16%. 2 studies reported an effect of complication on recurrence and 5-year survival, although in Beecher et al. Study it was related to all wound complications. And in the other study, the Glass et al. Suggested that in the presence of multiple comorbidities, the effect of complications on survival is lost. This suggested that frailty and comorbid conditions may have a more significant impact on survival in a population older than 65 years. Valente et al. Suggested that complications led to a delay in the commencement of adjuvant therapy, but without increased risk of recurrence. 2 studies reported readmission and need for revisional surgery, but neither studies reported a significant effect of complication of recurrence and survival. Seroma was classified in a complication in 3 studies. This was shown to affect recurrence and survival by Douglas et al. In the context of older patients who did not have comorbidities, and by O'Brien et al. In patients who had mastectomy versus mastectomy and immediate reconstruction, who tended to have significantly higher disease stage and specifically had higher seroma rates. Anemia, delirium, cardiovascular events, or thromboembolic disease had no effect on recurrence or disease-free survival. In conclusion, this systematic review and meta-analysis suggest that postoperative complications, namely infective wound complications and postoperative pyrexia, appear to be related to effect on recurrence and survival outcomes in certain studies. However, an equal number of studies suggests a lack of evidence on this topic. The meta-analysis was limited by the relative heterogeneity of outcome data. Different subsets of breast cancer, in itself a heterogeneous cancer group, may also have different effects of the local immune response, proposing that knowing the inflammatory landscape of the patient before surgery may also help guide decisions about surgical intervention by indicating the expected clinical outcomes. This may explain how certain groups, such as triple-negative patients or patients with higher comorbidity scores, had poorer outcomes, particularly in the context of reoperation for bleeding or postoperative pyrexia. The results of this review suggest that despite limitations posed by confounders and studies design, further research is justified. Using a well-defined and stratified population according to risk, age, and comorbidities, together with appropriate control of confounders and length of follow-up, may reveal how postoperative complications impact on prognosis in breast cancer. Thank you very much for your attention. A special thanks to Dr. Francesca Savioli, who is my current PhD student, and also to Professor John Edwards at Glasgow University for her support. Please feel free to ask any question, and thanks for listening again. Thank you very much.
Thank you very much, Mr. Laszlo Ramic, for sharing your knowledge and insight. I now welcome our esteemed guest, Mr. Amar Deshpande. Mr. Amar Deshpande is a consultant oncoplastic and reconstructive breast surgeon, and he is a lead breast surgeon in Royal Albert Edward Infirmary, and also which is in Wrightington, Wigan and Lee NHS Foundation Trust, Wigan, United Kingdom. And he is also a senior clinical lecturer in Edge Hill University. Mr. Amar Deshpande will talk about the future of breast reconstruction. Over to Mr. Deshpande.
Good afternoon, everybody. It's my privilege to be presenting this topic to you all today. And I would like to thank the organizers for giving me this opportunity. Reconstructive breast surgery and oncoplastic breast surgery are becoming more and more common with the breast cancer surgery, as breast cancer surgery is thought more in cosmetic terms nowadays. And naturally, with all these complex kind of surgeries, there are complex problems which can affect the cosmetic and aesthetic results after breast cancer surgery. Now, most of these problems are minor and very much acceptable by the patients, but the level of acceptability is different. And some of these then need to be corrected using reconstructive breast surgery or revision of reconstructive breast surgery as a matter of one of the options. Of course, careful planning of surgery preoperatively can minimize these problems to a certain extent and prevent further revision surgery. With breast reconstruction, there are a lot of problems associated, and most of these are minor and acceptable to the patients. However, some of these problems may need to be corrected, and some of the main problems are minor deformities, asymmetry because of the size difference of the reconstructed and natural breast. If an autologous flap is used, then some of these flaps can necrose. We may lose the flap completely or partially, or there might be some problems like fat necrosis associated with those. Animation or dynamic distortions is more associated with flaps where the muscles are used, like subpectoral implant-based reconstructions or latissimus dorsi flap, which are still innovated, used for reconstructions. Synmastia is mainly because of overzealous dissection medially, and the breasts merge with each other. When we use the implants, either for implant-based reconstruction or as a volume replace or as a volume supplement with latissimus dorsi flap reconstruction, can cause implant-related problems themselves, which are more commonly capsular contracture, displacement, and rupture, causing cosmetic or aesthetic problems. There are other risks associated with implant, like anaplastic large cell lymphoma, but these are outside the remit of my presentation today. Radiotherapy is something that can affect the results of what you get. For example, after a plain simple wide local excision, the radiotherapy can enhance the scarring, and that can cause puckering at the site of wide local excision. Of course, these need to be treated as the patient's expectations, etc., are, and whether the patients would like that to be corrected. Non-breast problems like donor area problems are there as well, which may need correction as well. For example, I had a lady who had recurrent seroma on her back after a latissimus dorsi flap reconstruction, and using Kenalog, etc., had not helped at all, and ultimately I had to go in and excise that cavity, and now she's fine. Now she's seroma free. But this was going on for almost 2 years before we decided to go ahead and excise that cavity. Breast conserving surgery is becoming more and more oncoplastic. So therapeutic mammoplasty is being used, round block techniques, etc., are being used. And that can also cause deformities, but deformities are more common with plain simple wide local excision, where there is a defect left at the site of surgery. And if we have not used oncoplastic techniques, then that might cause more problems, like puckering, asymmetry because of loss of volume, and also effect of radiotherapy. The deformities can be treated, and the commonest solution now we have got is micrografting, fat micrografting, or fat transfer. This can be associated with scar revision plus or minus glanduloplasty, especially after breast conserving surgery. And we can also use flaps, various flaps like intercostal perforator flaps, LD mini flaps, to correct the problems or correct the deformities. Post-reconstruction asymmetry is because of volume discrepancy of the reconstructed breast as compared to the normal breast. And this can be present mainly in very big or very small breasted ladies, or the ptotic, ladies with ptotic breasts. Flap atrophy is something that can happen with latissimus dorsi. It's known that latissimus dorsi flap shrinks by about a third of its volume. It can shrink up to by about a third of its volume because of disuse atrophy. And this then results in further asymmetry and needing further corrective surgery, etc. So contralateral reduction is commonest operation to correct the volume asymmetry. If the volumetric symmetry is good, but contralateral breast is more ptotic as compared to the reconstructed breast, then mastopexy is the option. And augmentation and reduction or refashioning of the reconstructed breast can be used if the patients feel that the reconstructed breast is too big or too small, or if there are any scar-related problems, etc., which which can be corrected by refashioning the scars. Post breast conserving surgery, there can be quite a bit of asymmetry, as I mentioned before, because of volume loss, and then radiotherapy causing some degree of atrophy in that breast, on the ipsilateral breast. And contralateral reduction can correct that problem. Also, because of radiotherapy, scarring, etc., sometimes the nipple levels are different, and contralateral mastopexy can be an option. Ipsilateral augmentation can be done if the contralateral breast is big and the patients do not want to go smaller on the other side, or other breast do not want the other breast to be touched. We can do this with implants, but radiotherapy can induce a lot of capsular contracture. And also because of wound-related problems, wound healing problems related with radiotherapy can also be a problem when ipsilateral augmentation with implant is performed. Yes, we can now use fat transfer as well as an adjunct to increasing the volume, and to the reconstructor, adjunct as volume for volume supplement to the reconstructed breast. Flap necrosis is about 5% with free flaps, but not so common with a pedicled latissimus dorsi flap. Pedicled latissimus dorsi flaps are more robust, and in my practice, I haven't seen a latissimus dorsi flap losing its blood supply and necrosing. If the flap looks dusky or purplish or bluish on immediate post-op, then it could be because of hematoma compressing the pedicle, or pressure from the dressings, or positional problems, kinks, etc. And immediate exploration of the pedicle and evacuation of hematoma or correction of the kinks, or redoing the macrovascular anastomosis, etc., can help to save the flap. Partial necrosis may be because of some degree of reduction in blood supply to some parts of the reconstructed breast, and this can be, if there is any distortion, then that can be treated with some flaps or fat transfer or refashioning of the breast or the scar, and contralateral surgery can be used as an adjunct to getting the symmetry right. When there is total flap necrosis, the flap may have to be sacrificed, and then a further form of reconstruction may have to be used at a later date after a period of recovery. Fat necrosis is quite common. It is because of inadequate blood supply to some parts of the reconstructed breast. Most of the times, conservative management is enough. However, sometimes when there is persistent pain or distortion, or discharge or recurrent infections, surgical excision or further revision may be needed. Further refashioning, lipomodeling may also be needed for getting the things cosmetically acceptable. Animation or dynamic distortion, as mentioned before, when the muscles are still innervated and they get adherent to the skin, this can cause major animation. Also, overzealous dissection of the pectoral muscle, especially in case of subpectoral implant placement, can cause more distortion as well. So, careful dissection, and also maybe you can try to put the implant in prepectoral position if the patient is suitable, so that the animation is not such a problem. Innervated latissimus dorsi flap also can cause animation. And these can be treated by, first of all, denervation of the muscles. However, denervation of muscles can be tricky. Fat grafting can help to a certain extent. And if it is a subpectoral implant that is used, then prepectoral placement can help. I've got an example later on to show you guys. Synmastia, or uniboob as it is called as, it's because of overzealous dissection medially so that the breasts merge with each other. It is a difficult problem to manage and may need more than one procedures to put it right. Capsulorrhaphy or acellular dermal matrix can be used to correct these problems with less incidence of failure or recurrence of the same problem. Implant-related problems are, implant is a foreign body after all, so those problems are to be anticipated and to be explained to the patients as well. Implant infection and implant loss is quite common. It can happen in about 5 to 18%. However, we can attempt to save the implant in early stages of infection by exploration, washout, antibiotic installation, IV antibiotics, and either changing the size of the implant or using an expander. However, if the infection is recurring, then explantation is the only choice, and then revision or redoing of reconstruction can be attempted after a period of recovery. Capsular contracture is quite high. The quoted figures are quite high, especially after radiotherapy or infection or previous capsulotomy. Capsular contracture can cause cosmetic problems if it is severe, but most of the capsular contractures do not cause cosmetic problems. The symptoms can be treated conservatively as well. However, if the capsular contracture is causing cosmetic problems, distortions, high riding implants, all these can be then treated by either capsulotomy or capsulectomy with change of implants. We can use acellular dermal matrix as a supplement to this because so far the studies have shown that acellular dermal matrix reduces the capsular contracture again. Polyurethane coated implants have been used as well to reduce the capsular contracture. However, that is, we don't know the long-term effects of polyurethane coating on the body, and therefore the uptake is not as much as we would otherwise expect. Recurrent capsular contractures may be treated with autologous flap, like say for example, deep inferior epigastric perforator flap, where the need for implant can be eliminated. In severe cases, the implant extrusion and skin necrosis can happen as well. I have seen an implant extruding 15 years after implantation. This was in a cosmetic case, and there was severe capsular contracture which actually caused the skin necrosis and implant extruded. Implant migration is because of weakening of the natural facial planes, and also implants have got some weight. The correction can be by using a smaller implant and rehitching or redefining the footprint of the breast, and other breasts can be used as a reference to that. Implant extrusion, we already mentioned that, and that is because of either infection or just sometimes there is no, there is only subclinical infection and implant certainly starts, you can certainly see the implant via the scar. Inadequate coverage, thin skin, etc. are also factors that can cause implant extrusion. So this can be revised after a period of recovery, and autologous reconstruction can be used to prevent further problems. Implant rupture is a natural phenomenon that happens after 10 to 15 years on average. But this is something that we are expecting to see less and less with new generation implants. Of course, if the implant is ruptured, then most of the patients would like that to be replaced. Capsular contracture actually causes folds on the implant casing, and because of shear stress, the implant rupture can happen earlier than it is supposed to or due to happen. Replacement of implants, capsulotomy, etc., can be used, and if there are if the implant was used, say for example with latissimus dorsi flap as a volume supplement, then to eliminate the use of implant, fat transfer can be considered to supplement the volume. And effects of radiotherapy, skin and wound problems are the most important problems with radiotherapy. And this can cause further problems if we have to change the implants or use the implants, etc., because that can cause more implant infection and implant loss. Deformities, capsular contractures, etc., are enhanced by radiotherapy because radiotherapy induces a lot of scarring, etc., cicatrization, etc. Asymmetry also can be caused after, especially after breast conserving surgery, because of scarring as well as some degree of atrophy that the radiotherapy may cause in the native breast. This lady had wide local excision from this area, and you can see that there is quite a bit of hollowness there, which was corrected with fat transfer with an acceptable result, and the lady is very, very happy with the results. This lady was one of my first latissimus dorsi flap reconstructions. She was a smoker. She had stopped smoking a couple of months before she came to see me with cancer, and but she ended up losing the implant to infection. Now, she did not want an implant to be inserted again. So, and she wanted something done. So I did about 4 sessions of fat transfer to get that result. We also did a mastopexy to get the nipple level higher, and also did a nipple reconstruction. Subsequently, she had areola tattoo as well. This next lady had bilateral reconstructions with myodermal flap technique, and ended up with dynamic distortion with animation. Now, this animation I tried to correct with some fat transfer with some degree of success, but it was not giving us the desired results, and therefore ended up changing the position from subpectoral to prepectoral with acellular dermal matrix on both the sides with acceptable results and no more animation. This lady is very happy as well. I have seen her about a year ago. This was done about 6-7 years ago, and she's absolutely fine. This lady had she had a cancer diagnosed at this site at 6 o'clock position of her right breast. She had cosmetic augmentation probably about 5 or 6 years ago before she presented to me. But she was very anxious and she just wanted wide local excision done. Naturally ended up with a Snoopy dog deformity. This was later on corrected with mastopexy on both the sides. And she's again very happy with the results. This lady had a subpectoral implant inserted. She basically had capsular contracture, and therefore there was distortion and deformity, and the implant was riding very high. Capsulotomy was done for this lady, and an implant which was slightly bigger as compared to the one we previously used was used. She also had some fat transfer. She could have had mastopexy on the other side, but she did not want to consider any surgery on the other side, and therefore she was left alone like this. She's very happy with the results as well. This case was particularly difficult. She had an expander and then the implant. But in the process, she had inframammary crease destroyed and the implant migrated inferiorly. Her inframammary crease, therefore, was much lower as compared to her left one. So this was corrected by capsulorrhaphy. And then I also reconstructed her nipple, and we did the nipple areolar tattooing. You can see from the lines that the right inframammary crease was a good 3 centimeters lower as compared to her left, and we got that corrected. This was done about 6 years ago, and this lady was seen for unrelated problems a couple of months ago, where her inframammary crease is still at the new raised level, and she's still happy with the results. Synmasty, as I said before, is a difficult problem to treat. It is a very unacceptable, cosmetically unacceptable problem. However, with the acellular dermal matrix and capsulorrhaphy along with it, it can still be treated. Any person who has acceptable results with first surgery like that is good. However, it is not possible in everybody, and therefore, with the newer techniques of breast reconstruction as well as breast conserving surgery, we are going to see more and more aesthetic problems which may need revisional surgery in future. Thank you.
Okay, thank you very much, Dr. Deshpande. And that was an excellent talk. I would now like to introduce Professor Ruth O'Regan, who's a professor of medical oncology and hematology at University of Rochester, United States of America. She's an internationally recognized oncologist with vast experience in breast cancer and clinical as well as in research. She has been voted as one of the top oncologists of the United States. So I'm really delighted to have her with me today in the Breast Cancer 1 session. She's going to talk to us about triple negative breast cancer. And I can see Dr. Qamar Khan also joining in the symposium. He will be in the question and answer sessions with us in session 1. So please welcome Dr. Ruth O'Regan. Thank you.
Hi, I'm Ruth O'Regan from the University of Rochester, and I'd like to thank Dr. Siddiqui for inviting me to talk to you today about triple negative breast cancer. So what I'd like to focus on is updates on treating patients with triple negative breast cancer from the ASCO meeting earlier this year, but more so from what was presented at the ESMO meeting in September. So we'll cover olaparib as adjuvant therapy for patients with BRCA germline mutations. We'll talk about preoperative management of triple negative breast cancer, specifically talking about the addition of carboplatin and checkpoint inhibition. And then we'll end talking about metastatic disease, both checkpoint inhibition and the new approval of sacituzumab vedotin. So firstly, just talking about patients with germline BRCA mutations. So I want to just briefly mention 2 abstracts that were presented at the ASCO meeting. The first one is the NeoTALA study, which was basically a phase 2 study looking at the use of talazoparib preoperatively in patients with germline BRCA mutations in HER2 negative breast cancer who were candidates for preoperative treatment. So you can see in the schema here that patients received six cycles or 24 weeks of talazoparib, then went to surgery, and the primary endpoint was pathologic complete response. So a non-chemotherapy approach for these patients. And looking at pathologic complete response, whether you look at the investigator measurement or the independent measurement, you can see the pathologic complete response rate in the intent to treat population was almost 50%. In the evaluable population, about 46%, as you can see shown here. So this is very encouraging data. It needs to be validated clearly, but it does suggest that there are patients with germline BRCA mutations who may be able to avoid chemotherapy. Since we would expect that patients who've got a pathologic complete response, particularly with triple negative breast cancer, have a very favorable outcome. The second trial to mention is the Olympia study, which of course was a plenary session at the ASCO meeting. And this was looking at adjuvant olaparib in patients with germline pathogenic or lightly pathogenic BRCA1 or 2 mutations with HER2 negative breast cancers. The eligibility in the neoadjuvant group, which is about 50% of the patients, if they did not get a pathologic complete response rate, they were eligible if they had triple negative disease. If they had hormone receptor positive disease, they also had to have a CPS EG score of greater than or equal to 3, which takes into account clinical stage, estrogen receptor status, grade, as well as pathologic stage. The adjuvant group, for the triple negative cohort, they had to have large cancers or node positive disease. And for the hormone receptor positive group, they had to have 4 or greater positive lymph nodes. And they were randomized to receive olaparib for a year or placebo for a year with a primary endpoint of invasive disease-free survival. By far, the majority of patients in the study had triple negative breast cancer. You can see over 80% shown here. And it was about a 50-50 mix of adjuvant versus neoadjuvant chemotherapy that was given to the patients. Here's the primary endpoint of invasive disease-free survival, showing a highly significant 9% benefit in 3-year invasive disease-free survival in the patients who got olaparib compared to the patients who got placebo. Looking at distance disease-free survival, again, similar results at 3 years, a 7% benefit for olaparib over placebo. You're looking at the statistics of the trial with the distant disease-free survival of p-value of 0.005. It meant for the overall survival to be significant, the p-value had to be less than 0.01. And at this time point, even though there's a meaningful 4% benefit in overall survival at 3 years for olaparib, as you can see shown here, the p-value is not quite statistically significant at this time point, but obviously there'll be further follow-up coming from this study. Looking at the forest plot for invasive disease-free survival, you can see the hazard ratio for patients with triple negative breast cancer was 0.56 compared to 0.7 for the hormone receptor positive group, and patients benefited whether they had prior platinum or not, although the majority you can see did not have, or whether they had a BRCA1 or BRCA2 mutation. So as we know, the majority of us do use preoperative chemotherapy in treating triple negative breast cancer, as it allows us to see whether the chemotherapy is working. And also, if patients obtain a pathologic complete response, they have a very favorable outcome, particularly as compared to patients who do not have a pathologic complete response, as shown here from this large meta-analysis that was published a few years ago. So the 2 questions to address here are, first of all, the addition of carboplatin to standard taxane anthracycline-based chemotherapy. So the GEPAR-6 study is shown here. Patients with triple negative breast cancer, stage 2 to 3, were randomized to receive the standard treatment, which was weekly paclitaxel with non-pegylated liposomal doxorubicin, along with bevacizumab alone, or with carboplatin given weekly. As we've seen before, the pathologic complete response rate was increased from 37% up to 53% with the addition of carboplatin. And that was statistically significant. The CLGB 40603 study, again a phase 2 study that looked at the addition of carboplatin alone, bevacizumab alone, or the combination of carboplatin and bevacizumab to paclitaxel followed by dose-dense AC in preoperative triple negative breast cancer. And again, the pathologic complete response rate was improved from 41% in the standard arm up to 54% in the carboplatin arm. These 2 studies have somewhat conflicting results looking at longer term outcome. In the CLGB study, there was no significant difference in event-free survival at 3 years between patients who got carboplatin versus those that did not. You can see there is a difference of 5%, but not significant, presumably because of the power of the trial. The GEPAR-6 study, however, at 3 years does show a significant improvement of about 9% in disease-free survival for patients who received carboplatin compared to the patients who did not. Now, the Brightness study, again, was triple negative breast cancer. Patients treated preoperatively. They either got standard taxane-based chemotherapy alone, or with the addition of carboplatin, or with the addition of the PARP inhibitor veliparib plus carboplatin. And what they found was, looking at pathologic complete response, it was significantly improved with the addition of carboplatin from 31% in the paclitaxel arm up to 58% in the carboplatin arm. The addition of veliparib did not further improve the pathologic complete response rate, as you can see. You can see the other endpoints shown here. What was just presented at ESMO was the longer term outcome from this study. So this is event-free survival at 4.5-year follow-up. And you can see, mirroring what we saw with the pathologic complete response, both the arms in which patients got carboplatin either alone or with veliparib, those patients did significantly better than the patients who got paclitaxel. So you can see 78% in the veliparib arm, 79% in the carboplatin alone arm, versus 69% in the paclitaxel arm. The overall survival doesn't at this time point show significant difference, although you can see the event rate was less in the paclitaxel carboplatin arm compared to the paclitaxel arm. So with longer follow-up, these curves may separate in favor of the carboplatin arm. So taken together, I think many of us do consider using carboplatin, particularly in patients with more advanced triple-negative breast cancer who need preoperative treatment. The second question is looking at the addition of checkpoint inhibitors to standard chemotherapy. So checkpoint 522 took patients with triple-negative breast cancer who were candidates for preoperative treatment and randomized them to paclitaxel weekly with carboplatin either given 3-weekly or weekly, followed by standard anthracycline-based chemotherapy and then surgery alone, or pembrolizumab, which as you can see was given throughout the chemotherapy and then continued for 9 cycles following surgery. The primary endpoint was pathologic complete response. So you can see the pathologic complete response was improved by 14% in the patients who got pembrolizumab with chemotherapy compared to chemotherapy alone. So 51% in the chemotherapy arm, up to 65% in the pembrolizumab arm. And that difference was seen regardless of how pathologic complete response rate was defined. Interestingly, in this setting, PD-L1 status did not appear to predict for benefit from the pembrolizumab. So you can see in the PD-L1 negative group, the difference was about 18% versus 14% in the patients with PD-L1 positive cancers. So we don't typically use this as a biomarker in this early stage setting in contrast to the metastatic setting. Keynote 522 earlier in the summer presented some longer term follow-up looking at event-free survival with a follow-up of 16 months, showing a 6% benefit in favor of pembrolizumab chemotherapy compared to placebo chemotherapy, as you can see shown here. The JEPR-NERIVO study, again, looked at the addition of checkpoint inhibition with standard chemotherapy. In this case, they used durvalumab, as you can see shown here. So durvalumab was started 2 weeks before chemotherapy. They then received either nab-paclitaxel with placebo or with durvalumab, and then received EC either with placebo or durvalumab, as you can see shown here. Primary endpoint again was pathologic complete response. And that was improved from 44% in the placebo arm up to 53% in the durvalumab arm, as you can see shown here. The p-value was not quite statistically significant. However, looking at longer term follow-up, invasive disease-free survival is shown here. You can see about a 9% benefit for the addition of durvalumab with a follow-up of 44 months. That was statistically significant. And looking at distant disease-free survival, again, pretty impressive, about 13% benefit in terms of distant disease-free survival for the addition of durvalumab to standard chemotherapy versus placebo. And even looking at overall survival, you can see a 12% difference shown here. So really impressive results. And these all really speak to considering the addition of both carboplatin, although this study didn't, both carboplatin and a checkpoint inhibitor in patients with more locally advanced triple-negative breast cancers. So moving on to the metastatic setting. So the Impassion 130 trial is shown here. This took patients in the first-line triple-negative breast cancer setting and randomized them to receive nab-paclitaxel alone or nab-paclitaxel with atezolizumab. Looking at progression-free survival, you can see the difference is about, in the PD-L1 positive group, it's about 2 months in favor of using atezolizumab. There was no benefit seen in the 60% of patients who had PD-L1 negative cancers, as you can see shown here. And looking at overall survival in the PD-L1 positive group, there was about a 7-month improvement in outcome for the addition of atezolizumab, compared to no difference, as you can see in the PD-L1 negative group. The second impassioned study, 131 design, is shown here. So again, this is a first-line study, triple negative breast cancer. In this instance, patients received paclitaxel weekly at 90 milligrams per meter squared with either placebo or with atezolizumab. I'm looking at the intent to treat population shown over on the right-hand part of the slide. You can see there's about a 3-month benefit or difference, but 3-month difference, but actually it's in favor of the placebo arm, as you can see shown here. So no significant difference between the two arms. If you look at the PD-L1 positive group, again, you can see no difference and no benefit for the addition of atezolizumab, as you can see. And here, so sorry, this is overall survival in the group. And looking at progression-free survival in the PD-L1 positive group, you can see there's about just not really any difference and no significant difference in favor of the use of atezolizumab in these patients. So overall, this was a negative trial. So with both of these trials, with survival difference in the impassioned 130 study becoming less robust with longer follow-up, and this negative study shown here, Roche elected to withdraw FDA approval or request withdrawal of FDA approval for atezolizumab used in the first-line setting. Now moving on to pembrolizumab, this is Keynote 355. This was a study, again, first-line triple-negative breast cancer, where patients were randomized to receive chemotherapy with placebo or chemotherapy with pembrolizumab. The chemotherapy could be nab-paclitaxel or gemcitabine carboplatin. You can see looking at progression-free survival in the intent to treat population, there was a 2-month improvement for the addition of pembrolizumab compared to placebo. Broken down on CPS, the CPS shown here, if it was greater or equal to 1, which was 75% of patients, there was again a 2-month benefit for pembrolizumab, which was statistically significant, as you can see. However, when you look at specifically at patients with CPS greater or equal to 10, which was 40% of patients in the study, which is a very similar number from the impassioned 130 study. You can see there's a more meaningful benefit in progression-free survival. You can see 4 months, you can see, and you can see that was statistically significant with a hazard ratio of 0.65. Now, what we just saw at ESMO was overall survival from this study. So what you can see here is that this is for patients who have PD-L1 CPS greater than 10, so the patients that got the greatest benefit of progression-free survival. What you're seeing here is an improvement of about 7 months in favor of the pembrolizumab arm, so 71% versus 82%, as you can see. And that was, as you can see, statistically significant. And looking at the 2-year overall survival, it was 34% in the chemotherapy arm versus 48% in the pembrolizumab arm. Again, as perhaps you would have expected, if you use the lower cutoff of CPS of greater or equal to 1, which again was 75% of the patients, the difference is now only about 1.5 months in favor of pembrolizumab. Not statistically significant. And you can see the difference after 2 years is 30% in the placebo arm versus 38% in the pembrolizumab arm, as you can see shown here. And focusing just on the CPS greater or equal to 10 group, looking at overall survival, what you can see is it didn't matter what the chemotherapy backbone was. You can see there was a clear benefit for pembrolizumab. And interestingly, including with paclitaxel, which is kind of a complete contrast to the impassioned 131 study. And you can see all of the other stratification factors, patients did appear to benefit from pembrolizumab when they had a CPS of greater or equal to 10. And lastly, just to talk about sacituzumab govitecan. As you probably know, this is an antibody drug conjugate in which the chemotherapy payload is conjugated to an antibody that targets TROP2, and TROP2 is present in the majority of triple-negative breast cancers. The ASCENT study was the registration study for sacituzumab. It took patients with metastatic triple-negative breast cancer who'd received at least 2 lines of chemotherapy for advanced disease. And they randomized just over 500 patients to receive sacituzumab, which is given on a day 1, day 8, every 3-week cycle, or physician's choice of chemotherapy. So any single agent chemotherapy was allowed. The primary endpoint was progression-free survival, and the study was halted early based on a DSMB recommendation due to efficacy. So here are the results looking at progression-free survival. You can see here a highly significant benefit for sadutuzumab. The progression-free survival was less than 2 months in the chemotherapy arm compared to 6 months in the sadutuzumab arm, as you can see shown here. The curves separate very early in favor of the antibody drug conjugate. And even looking at overall survival, there was a doubling in overall survival, or almost doubling, about 7 months in the chemotherapy arm compared to 12 months in the sadutuzumab arm. And again, see the curves separate quite early in favor of sadutuzumab. Overall, pretty well tolerated, some neutropenia and diarrhea with this drug, but it is now approved for patients with pretreated triple-negative breast cancer. Although the study did use specifically third line or beyond, I think many of us are using it second line after patients have completed their first-line chemotherapy. So in conclusion, I think this is a very exciting time for triple-negative breast cancer. We actually have more drugs approved or recommended from some of these trials. So the data with olaparib obviously is very encouraging. It seems very effective as adjuvant therapy for patients with BRCA mutations. And remember that the majority of patients in the Olympia study had triple-negative breast cancer. I think based on the longer term follow-up from some of the trials, adding in carboplatin to standard taxane anthracycline-based chemotherapy makes sense, at least for some patients with triple-negative breast cancer. And I think from the Keynote study and the Jeopardy study, the addition of checkpoint inhibition should certainly be considered in patients with higher stage triple-negative breast cancer. I think based on the trials we've seen that the addition of both carboplatin and a checkpoint inhibitor does increase the rate of pathologic complete response rate. And I think the longer term follow-up is improved in the majority of the trials, which certainly supports considering use of these agents. In the metastatic setting, it's a little bit less clear. I think the longer term benefit of checkpoint inhibition in metastatic disease does remain unclear. Obviously, atezolizumab is no longer available in the first line setting. The Keynote study obviously is encouraging as well, but I think obviously longer follow-up of that study will be important. So thank you very much for your attention.
Thank you very much, Dr. Ruth. That was a brilliant presentation. I would now like to invite Dr. Mohammad Jahanzeb as the next speaker. Dr. Jahanzeb is the Chief Medical Oncology Scientific Advisor at 21st Century Oncology. He was previously a professor of medicine at University of Miami. He's an international lecturer. He's given, I think, more than 900 talks, and he's also been on the board of NCCN for breast cancer and lung cancer. So it's my privilege to welcome Dr. Jahanzeb to give us the next talk, which is about breast cancer metastasis to the brain and leptomeningeal disease. Thank you.
Good afternoon. It's early morning in the United States, but it's a pleasure to be talking to you. I wish I was there in person, but you know the circumstances around the world right now. The topic given to me today is to talk about current recommendations for breast cancer brain metastases and leptomeningeal disease in triple-negative breast cancer and HER2-positive breast cancer. These are my disclosures. So brain metastases are a devastating, feared, and increasingly common consequence of breast cancer because as patients are living longer and longer, there's more years at risk to develop brain metastases. And studies vary a lot by whether you are talking about de novo brain metastases at presentation or over the entire lifetime of a patient. So these numbers can vary, but you see selected studies here, 46% for triple-negative breast cancer, 34% for HER2-positive breast cancer, and hormone receptor positive is about a third as common. So I will not be talking about those brain metastases except for one other reference. Blood-brain barrier, which is tight capillary junctions of the brain, evolved to protect the species brain damage. That doesn't allow many of the drugs, and some that do cross into it, they are pumped out through the efflux pump in the brain. And large molecules, such as antibodies, cannot enter that barrier for sure. One can argue that in patients with visible brain metastases, that barrier is already interrupted, and that's why we see a finite response rate for all sorts of chemotherapeutic agents in the brain with visible brain metastases. Until recently, preclinical model systems were scarce, and clinical trials frequently excluded patients with brain metastases. So this is from a study from 2019. On the left-hand side, you see CNS metastases-free survival, and the green curve is hormone receptor positive HER2 negative breast cancer patients, which is the largest subgroup of breast cancer in general. And at the bottom two lines, purple and red, you see triple negative and HER2 positive breast cancer patients who have the shortest CNS metastases-free survival. On the right-hand side, you see overall survival from diagnosis of CNS metastases. And interestingly, you notice that the green line, the ER positive HER2 negative, drops to third from the top rather than the top curve, because by the time you develop brain metastases, even though they're less common, ER/PR positive patients are very heavily pretreated and further down the line in their natural history. So they actually do worse than HER2 positive patients. And triple negative patients remain at the bottom regardless. So if you go to NCCN guidelines for breast cancer, you will not find this slide. This is in fact in the central nervous system guidelines. And those are separate guidelines, whether it's primary or secondary cancer to the brain. And in those guidelines, according to the latest snapshot that I took a couple of days ago, HER2 positive patients are recommended TDM1 or capecitabine lapatinib, capecitabine neratinib, paclitaxel neratinib, which is category 2B. Category 2B means there's some disagreement among the panel. And tucatinib, trastuzumab, capecitabine is category 1, which means complete consensus of the panel with high-level evidence, such as randomized trials or meta-analysis. Anytime there's no category written with NCCN guidelines, it's implied that it's 2A, which is 85% of recommendations, which means complete consensus of the panel, but lower level of evidence. And then for HER2 non-specific patients, there are chemotherapeutic agents, capecitabine, cisplatin, etoposide, cisplatin plus etoposide, high-dose methotrexate. And you'll notice that other than capecitabine, everything is 2B, which means incomplete consensus of the panel. So what should be the initial approach to brain metastases? Of course, a scenario where somebody presents to the emergency room with a seizure, and on brain imaging, they're supposed to, have some evidence if there is cancer, because MRI is a sensitive test. You find multiple brain metastases. You then do a workup. You'll often find the primary elsewhere. However, there are situations where the solitary brain met, no evidence of anything elsewhere, then neurosurgical approach is preferred, because you not only take out what's causing symptoms, but you get a diagnosis. So you need tissue diagnosis if there's no other place to biopsy. But if there are other places to biopsy, we do not do a biopsy of the brain. We avoid biopsy of the brain whenever possible. Once you have done resection, gross total resection of the brain lesion, if it's a solitary lesion, then you do postoperative radiation to the resection cavity only. Previous standard of care used to be whole brain radiation after resection of the tumor. That has changed now to just stereotactic radiosurgery of the tumor bed. So we avoid whole brain radiation at all costs these days, because patients are living longer, and they're living long enough to see the consequences or sequelae or neuropsychiatric deterioration from whole brain irradiation. Now, this is showing you a study, SRS, which is stereotactic radiosurgery, versus whole brain radiation therapy after resection of brain metastases. As you see on the left-hand side, for cognitive deterioration, it's much worse to do whole brain irradiation. SRS is superior. And if you think patient survival may suffer because you did not radiate the whole brain, On the right-hand side, you see that that is not true. Overall survival was equivalent in the two arms of the study in this trial of 194 patients. Now, in another randomized trial of SRS with or without whole brain radiation, to see if it makes any difference to cover rest of the brain, because the thought is that when one spot is involved, there may be microscopic seeding of other parts of the brain. And that's a good theoretical concern. But here, as you see, SRS plus whole brain irradiation was no superior to SRS alone. So again, we do not do whole brain irradiation after SRS in patients with few numbers of metastases. Now, for multiple brain metastases, there's this prospective observational study. And in this study, patients with solid tumors, not just breast cancer, were included. And on the right-hand side, you see the green line, that's for one tumor. So single tumor patients have the best survival. 2 to 4 tumors and 5 to 10 tumors, survival-wise, were no different. And on the left-hand side, you see that in patients with 2 to 4 versus 5 to 10 brain metastases, there were no significant differences in median overall survival, cumulative incidence of repeat SRS, or salvage whole brain irradiation. Neurological deterioration was also not different. But median OS in breast cancer cohort, as one would expect, decreased as the number of lesions increased. With 1 lesions, 27.2, 2 to 4 lesions, 13.7 months, 5 to 10 lesions, 10.5 months. Now, another consideration is to spare hippocampus, because major reason for deterioration in memory is hippocampal irradiation, because that's the part of brain that converts recent memory into long-term memory. So if you cover the hippocampus, as you see on top, where hippocampus get only 8 gray and rest of the brain gets 30 gray, versus the other arm where the whole brain, including the hippocampus, got 30 gray. On the right-hand side, you see that whole brain radiation had a higher incidence of neurocognitive failure as opposed to hippocampal avoidance whole brain radiation. Both groups called memantine, which is a neuroprotective agent. Now, these are selected phase 3 trials of RT ongoing for brain metastases. You see the trial sponsor, various institutions, treatment arms. They all are comparing either hippocampal avoidance or some other permutation of the timing or sequence of stereotactic radiosurgery. And primary endpoints vary from neurocognitive PFS, overall survival, leptomeningeal disease-free survival, composite CNS endpoint, or surgical bed relapse-free survival. So stay tuned for these studies, but as you can tell, the focus of research is to get rid of whole brain and fine-tune the best way to give SRS and ways to protect neurocognitive damage of the brain and ways to protect time to leptomeningeal disease or relapse in the brain. There's also a movement afoot to take small molecule tyrosine kinase inhibitors and other small molecules that would cross over into brain and use those to control brain disease and delay the onset of radiation therapy as much as possible. So this study for Alliance, which used to be called CLGB, they do central pathology review and tissue sequencing. And according to what's found in next generation sequencing, they pick drugs matched to those pathways. And you see that they want to enroll 21 patients per cohort of lung or breast in various target types. And NTERC is very, very rare, 0.3% or so. ROS1 is also rare in about 1% of the patients. So that number is only 10. Otherwise, they'll never reach accrual. And they would give these systemic targeted therapies until patient needs something further. So that'll be an interesting study. There's also evidence of deficient DNA repair in breast cancer brain metastases. And as you know, PARP inhibitors are used in that setting. So these patients are probably better candidates for a PARP inhibitor. And these metastases show increased level of genomic aberration based homologous recombination deficiency, or RCD scores, which is another cohort of patients considered to benefit from PARP inhibitors, even though it's more controversial than BRCA mutated patients. And here you see EMBRACA, a trial for talazoparib versus physician's choice of chemotherapy in BRCA-associated brain metastases. Here you see the subset of patients that had brain metastases, only 63 patients. If you recall, the main randomized trial showed 2-month improvement in PFS from 5 months and change to 7 months and change compared to chemotherapy in favor of talazoparib. Here's 63 patients who had brain metastases. Only 20 were in the standard chemotherapy group, 43 in a talazoparib group. And you can see that median PFS was more than tripled in that group of patients, from 1.6 months to 5.7. This is a swimmer's plot, which also shows you the response CR in circles and PR in triangles, and progressive disease in hollow triangle, and stable disease in a solid square. And the length of the arrow is the duration that the patient has ongoing response. And you can see the complete responder at the top is out to 20 months. So this shows you the whole population of patients and how long they are in response, which is very instructive. And you can see that a subset of patients does very well with a combination of niraparib, another PARP inhibitor, with immune checkpoint inhibitor, in this case pembrolizumab. Now, another study of pembrolizumab, which included solid tumor patients with standard dose of pembro at 200 milligrams every 3 weeks, given until CNS or systemic progression, with primary endpoint of overall survival rate at 3 months. Secondary endpoints shown here: overall response rate, CNS and systemic PFS, as well as safety, and exploratory endpoints of correlation of response with biomarkers, etc., showed a 3.6-month median overall survival in the cohort with leptomeningeal disease, which has a dismal prognosis, as you know. 12 out of 20 patients remained alive 3 months after enrollment, and a 3-month overall survival rate for patients who received at least 1 dose, that was 20 patients, is what constitutes this curve. Hazard ratio was 0.6. Now, phase 2 study looking at best response with pembro in leptomeningeal disease cohort in this study is shown here. Note that no one had a partial response. It was either progressive disease or stable disease. But stable disease intracranially was 55%, extracranially 50%, which is not trivial for this patient population. Now let's quickly switch gears to HER2 positive disease, where CNS metastases are also very common. There are small molecule tyrosine kinase inhibitor combinations, mostly with capecitabine, that we'll talk about. And now a recent advent of antibody drug conjugates like TDM1 and trastuzumab deruxtecan have employed them as well to see if they can be helpful in this situation. So first, lapatinib plus capecitabine. This has been tested in many studies. The number of patients varies between 13 to 138 in the left-hand column, as you see. Nearly every study had prior RT exposure. A couple of studies had 100% radiation-treated patients. The very last study at the bottom, Bachelot, that had no radiation exposure, and that's why you see CNS overall response rate of 66% in that population of patients. Median time to progression was also the longest in that study, and overall survival in that study, 91% alive at 6 months, is the best that we can expect. If you look at studies that looked at single agent lapatinib, the response rates are only about 6%. When you add capecitabine in untreated population, it rises to as high as 66%, but in pre-treated patients is 18%. to 38%. Cerebral was a large randomized trial where anybody with metastatic HER2-positive breast cancer who did not already have brain metastases could enroll, and they were followed on 2 different therapies to see which subgroup develops more brain metastases and sooner. And combinations were lapatinib, capecitabine versus trastuzumab, capecitabine. And the hypothesis was lapatinib, being a small molecule tyrosine kinase inhibitor, would show much better results than trastuzumab, which does not penetrate into the brain. However, on the right-hand side, you see that in 500 patients that were enrolled, which was short of the total of 540 planned, numerically CNS metastases were fewer, 8 versus 12 in lapatinib arm compared to trastuzumab. But if you go further down to median progression-free survival, that was inferior by 2 months with a significant p-value in favor of trastuzumab doing better. So the trial was closed early for futility. So lapatinib is not any great shakes in this situation, even though people have thought that in the past. Now neratinib, a newer compound, has also been tested on the left-hand side in a randomized phase 3 with paclitaxel versus trastuzumab paclitaxel, and on the right-hand side with capecitabine in a phase 2 study. And you see that it was superior to trastuzumab in combination with paclitaxel in a trial of 479 patients. On the right-hand side, you see clear-cut activity with the shrinkage below the baseline in 49% of patients. Now, NALA trial led to the approval of neratinib with capecitabine in the United States, and the design is shown here. If you look at progression-free survival, it was prolonged by 2.2 months. Overall survival was not different, but it led to approval nevertheless. When you looked at time to intervention for CNS metastases, overall cumulative incidence was lower, 22.8% compared to 29.2% in the lapatinib containing arm. So I would point that these are 2 small molecule tyrosine kinase inhibitors compared to each other, not trastuzumab compared to the small molecule. And yet there was superiority. Tucatinib is the newest compound. It's a selective tyrosine kinase inhibitor because the other 2 also inhibit EGFR. When you inhibit EGFR, which is found in skin and mucosa, you have the side effects of rash and diarrhea, as we are very familiar with EGFR TKIs. However, the inhibitory concentration of tucatinib required to inhibit EGFR is several hundredfold higher, or 500-fold higher to be exact, compared to HER2, 8 versus 4,000, whereas for neratinib and lapatinib, it's very close numbers. So that's why tucatinib is supposed to have less skin and mucosal toxicity, so better therapeutic index, and it does penetrate into the CNS. His phase 1b study with tucatinib plus capecitabine with trastuzumab, and you can see responses. On the right-hand side, you see the triple combination in 23 patients showing 61% response rate. And then HER2 CLIMB trial, which led to the approval of this triplet in the United States. Design shown here, it was a placebo-controlled trial where tucatinib or placebo added to the backbone of trastuzumab capecitabine. This was the overall PFS result with a 2-month prolongation, and overall survival prolonged by 4 months, which led to the approval. And looking at the subset that had brain metastases, 291 patients, of whom 117 were stable treated, 174 were deemed active, of whom 108 had progressed despite prior therapy, but 66 were completely untreated. And MRI was done every 6 weeks in first 24 weeks, so very close follow-up. Here's the astounding result, 0% CNS progression-free survival in the control arm compared to 40%. So that's pretty convincing. And then if you look at overall survival, Again, it was 46 versus 70 at 12-month mark. So you can say that there's 24 additional lives saved. And this is, again, a subset with active brain metastases. In that difference, 0 versus 35% for PFS, and for overall survival, again, a 30% difference. This is subset with stable brain metastases, where the differences in overall survival are far less dramatic and not significant, but still significant difference in progression-free survival. So FDA approved both neratinib for NALA in February of last year, and tucatinib from HER2 CLIMB in April of last year. So TDM1, an antibody drug conjugate, also has activity in single case report, followed by 10 patient series, 39 patient series, and an 87 patient series with overall response rate ranging from 24 to 44%. Here's Camilla exploratory analysis from TDM1 with brain metastases. You see a lot of responders, overall response reaching the criteria of 30% shrinkage here by RECIST, however, was only 21.4%. Clinical benefit rate was close to 43%. So now early clinical trials of TDM1 are looking at combining it with tucatinib or neratinib. That's currently being tested. Destiny phase 2 trial that led to provisional approval of trastuzumab deruxtecan shows PFS in patients with brain mets, which was 18.1 months, no different than the overall population, but these were treated stable brain mets. And Destiny Breast03 that just got presented at ESMO showed more impressive results with the PFS vastly different, 34 versus 75% at 12-month mark. And all subgroups seem to substantially benefit with no confidence interval touching unity. In terms of the dismal leptomeningeal disease, intrathecal trastuzumab has been tried, and recommended phase 2 dose was an astounding 80 milligrams. If brain is 1 kilogram, it should probably be closer to 6 milligram per kilogram that we order for rest of the body. But in this trial, patients were treated via Ommaya reservoir twice weekly. Dr. Ommaya from King Edward, of course, we remember that, and we are proud of that. So this is the response rate of 20%, but stable disease another 50%. So in the past, not so distant past, history of brain metastases used to be an exclusion criteria. Now trials are designed specifically for patients with stable or progressive disease, and NCI and ASCO support that. These are all the select ongoing trials of systemic therapy. I won't belabor these, but you can see a lot of work is being done to add systemic therapy for brain metastases in HER2 positive disease. This trial specifically after HER2 CLIMB is a phase 2 study for leptomeningeal disease, which has dismal prognosis. So I hope it turns out with good results. So in summary, brain metastases are common in triple negative breast cancer and HER2 positive disease and carry devastating consequences. Local therapy has increasingly shifted to SRS. Whole brain radiation is to be avoided. If whole brain radiation is needed, hippocampal sparing is desirable. Several systemic therapies have limited activity. New TKI-based therapies, especially tucatinib, have substantial activity in HER2 positive subset, and intrathecal trastuzumab for leptomeningeal disease in HER2 positive patients still remains experimental. In the end, I acknowledge clinical care options for many of the slides I showed you, and their creators, Drs. Ruth O'Regan, who is in this session, and Dr. Lee Schwartzberg, who's not. Thank you very much for your attention.
Okay, thank you. So I'm sorry we're running a bit late, but it's lovely to see Dr. Ruth O'Regan join us for the question and answer. So really short of time, but we do have all the speakers here. Dr. Kamal Khan has also joined. So we've got, and Dr. Jahazeb as well. I thought you were sleeping, Jahazieb.
Oh, no, I'm pretty much awake
Yeah,
by now.
but I think the three of you will be there in the second session as well. So we've got a couple of questions for the surgeons. One was about inflammatory breast cancer, that if you're able to conserve the breast in this time and era. So if we have one of the surgeons here with us.
I'm sorry.
Yes, yeah.
Hello. So yeah, the standard treatment for inflammatory breast cancer would be mastectomy and axillary clearance. We have published our data, I think it was in 2018, in the whole UK about the surgical experience of inflammatory breast cancer. There was very few breast conservation in that database, so it does exist, but it needs to be extra caution. And certainly in my unit in Glasgow, we are doing mastectomy with no immediate reconstruction and axillary clearance, because sentinel node biopsy has no rule in the very few cases, even when it's clinically node negative disease.
Thank you. So there's another question about recurrence of cancer and the reaction of flap in that conditions. What complications occur at flapped breast in the recurrence rate in case of breast cancer?
Could this question be rephrased? Because I read it, but to be honest, I didn't understand that. Is it about immediate? Is it about recurrence in immediate breast reconstruction with autologous? And what is the recurrence? Or
it doesn't say that. It just says about the recurrence of cancer and the reaction of flap in that condition.
I think this question should be put to Mr. Deshpande. I think he was one of our surgeons who was giving us a talk about the future of breast reconstruction.
Okay, I think he's not with us anymore.
I think in general, if you have a recurrence after immediate reconstruction around in the flap, then that flap needs to be removed. It's obvious it's coming from the remaining breast tissue and not from the autologous flap, but the current treatment is the removal of that flap, certainly, and then take it from there. What else can be done? But I'm not sure if that answers the question, if that was the question.
Yeah, okay. Thank you, but I think we'll just move on because we've got so Dr. Ruth O'Regan, thank you very much for your talk on triple negative. We will have a case on triple negative breast cancer in the next session as well. But just quickly, what is the role of PARP inhibitors in a patient who's had pathological CR? So would you still consider some patients, especially the one who had, if some patient had locally advanced disease in the beginning? So somebody gets diagnosed with T3, N3, really advanced stage disease, gets a pathological CR with just standard chemotherapy, and so do you want to like give something more? Is that so baseline, importance of baseline disease burden in triple negative disease?
Yeah, I mean, it's a good question. I mean, I think they weren't included in the study, right? So it's kind of a data-free zone. I think, I probably would not recommend a PARP inhibitor because we don't know if it's going to be efficacious in that setting and there is more toxicity with it. But I still think it's worth a conversation with the patient. I think, though, if they had any residual disease, for sure, I would think about it. So, but if it's a complete pathologic, complete response, probably not at this point. I think you're muted.
Can't hear you.
Yeah, we cannot hear you.
Yeah, can you hear me now?
Yes.
No, the organizers have been very kind and said they've given us 10 extra minutes. So that's, like a sigh of relief. So Shahina, did you want to say something about it? You joined it later. Hello, Dr. Shahina Daud.
Yes, I'm here. I've actually been quite
It's
some time.
lovely to see you here. So my session 2 speakers are, joining now. So that's really, that's very good. So it was just I'd asked Dr. Ruth about role of PARP inhibitors in a triple negative patient who had locally advanced disease in the beginning, gets a pathological CR, and then would you give PARP inhibitors or not?
That's actually a very interesting question. We had a roundtable discussion of KOLs in August after the Olympia study came out. We had Hope Rugo, Sudeep Gupta, Giuseppe Kirgliani, Javier Cortez, like the whole 9 yards. We had like 10 KOLs, and we actually sent a survey to them prior to the discussion, asking them this very same question. If a patient has a locally advanced say N3 disease, T4D, but attains a pathological complete response with a BRCA mutation, would you give them or would you consider giving them adjuvant PARP? The consensus was exactly what Professor Ruth said. It's a data-free zone, important to have that conversation. But interestingly enough, the majority of the KOLs actually said that they would advocate for it, but with the caveat that it is a data-free zone and that we would need to have that open conversation with the patient, because the risk of recurrence is high. And I think the concept is that not all PCRs are the same. Initial stage of the disease also makes a difference.
Yeah, I think that's very helpful because I have a patient just like that. So I've got one of our ex-fellows, he's in UK now. So he's in England. So he's saying, I've got a patient with triple negative breast cancer. She's young. She had poor clinical response to neoadjuvant chemo, but tolerance was good. So after 4 cycles of AC and 2 cycles of carbopaclitaxel, she got her wide local excision done. Histopath shows YPT2 and 0. So she didn't have complete chemotherapy and she still has residual disease. So should we complete remaining cycles of carbopaclitaxel first or directly switch to capecitabine? Or maybe, this is Dr. Jahanzeb Iftikhar, or maybe do both. So Kamar, Dr. Kamar Khan, maybe you could elaborate on that. So this is a patient with triple negative breast cancer, couldn't complete all the cycles of chemotherapy because of tolerance and has residual disease on surgery.
Yeah, so I think this is another area where, nobody really knows the answer to this question. She clearly has chemo-resistant disease. So I would actually favor completing the adjuvant treatment and then giving her capecitabine, as was pointed out in, based on the CREATE-X trial. But I think it's again one of the areas where the question, it's a question that nobody really knows the answer based on the data.
So Dr. Jahanzeb.
Yes.
I mean, you weren't very happy when I gave you the topic because brain metastasis, especially leptomeningeal disease, is really difficult, and you know how frustrating it is. So normally in your clinical practice, if you have a patient with triple negative breast cancer and young patient just finished chemotherapy and comes to you with leptomeningeal disease, how do you go about it?
Yeah,
especially
young patients.
The CSF studies, yeah.
Yeah, sorry. So first of all, let me say that the difference between a difficult and an easy topic as a speaker is whether you have the slides or don't have the slides. Otherwise, we keep taking care of these patients in all situations. It's not easy or difficult. So Dr. Ruth O'Regan, who I gave credit, made it easy by having a talk online. And I was able to borrow heavily from that. But having said that, this young patient, leptomeningeal disease, of course, is very bad news. And leptomeningeal disease is much worse than having parenchymal brain metastases with much shorter survival. Somebody asked the question in the chat, would you do prophylactic intrathecal therapy in some patients? The answer is no, that's too drastic for prophylaxis. And you won't know how long to prophylax for. So I would not do that. Therapeutically, intrathecal therapy traditionally has been around. It has fallen out of favor largely due to lack of dramatic efficacy. Intrathecal methotrexate was used, intrathecal RC, depot RC has been tried. As we know, RC is a leukemia drug, and we don't expect much out of it in breast cancer. So right now, it's experimental to do intrathecal therapy with newer agents. And, for HER2 positive, I showed that there's experimental data. It's not mainstream yet. There was a question in the chat about immunotherapy intrathecally. That, of course, would be deemed experimental. So craniospinal irradiation for symptomatic disease is what I employ. I would love to hear from other panelists what they employ in such patients. But I must also add that I saw a lot more leptomeningeal disease in earlier part of my career than I see now. It's been decreasing largely, I think, due to the increasing efficacy of systemic therapy. So I would love to hear from other panelists.
So if anybody wants to comment, come up.
Yeah, I agree with MJ. I think depending on the extent of the disease, I don't really use Ommaya reservoir in these patients, based exactly by Jahanzeb basically pointed out. So the two options that are there, and both of them are not very good in terms of outcomes, is radiation and also high-dose methotrexate. So I have in selected patients who basically have an excellent performance status, I have used high-dose methotrexate, but again, it's not based on any kind of a huge long randomized trials in breast cancer. So those are the two options that I would consider.
So what about eribulin in triple negative breast cancer? Does it work for brain mets? And irinotecan? Any experience with irinotecan?
There are trials of liposomal irinotecan, actually one trial exclusively for brain metastases. And now we know from the FAM trastuzumab DX that irinotecan has been a neglected drug in breast cancer. It's highly efficacious. It just hasn't been developed. So when you ask, is there a role? Of course. We know that when there's visible brain metastases, blood-brain barrier has been disrupted. And starting from the old literature, there's a finite response rate for any chemo drug that has been tried that's active in breast cancer, anywhere between 10 to 20% response rate. So yes, one would try it. Whether it works or not remains to be seen for an individual patient, but there is no reason not to try these agents in a triple negative situation.
And I think there is some data with sacituzumab as well, showing some activity in the CNS, from what I recall. But I think we all have to accept that leptomeningeal disease, especially in triple negative breast cancer, has just like a horrible prognosis. And I think that's why, giving intrathecal just doesn't make any sense, just not effective. And it's just very limited options, unfortunately.
Okay, so any last comment, Shahina? Because we've got.
I just like to say that for the last 2 years, I've been on multiple forums like this, and I have been strongly advocating the use of irinotecan in triple negative breast cancer. And we have a lot of experience at our institute. I do a lot of irinotecan. I feel like it's a poor man's version of sacituzumab and trastuzumab deruxtecan. And I've combined it with trastuzumab. I've combined it with bevacizumab, and it works. We've seen it work. It doesn't work as well because you can't obviously give you very high doses of it, but it works. And I've had patients with triple negative breast cancer who've failed multiple lines, but have had stable disease for a long period of time on small doses of single agent weekly irinotecan. So I would strongly advocate using it.
Thank you. And you talked about bevacizumab. So, like, anyone wants to talk about the current role of Bev in triple negative breast cancer or any breast cancer?
I'll let Dr. O'Regan start off with that.
Well, I mean, unfortunately, there's not much I can say about it because obviously, the FDA pulled the approval over here. But, I think if you remember the trials that were done, the one group that did appear to benefit were patients with triple negative breast cancer. So if I was able to access it, I would probably consider using it in selected patients. But I don't know, in Pakistan, you may still have access to it because I know that outside the US, it is still being used.
We do have bevacizumab for ovarian, so we could probably get the approval for that. So that's fine. So anyways, I think I've got the intimation that we have to stop here. And I would really like to thank all of you for your excellent talks and the panelists for your contribution. And hopefully we'll see you next year again and in person. That's my sincere hope. So thank you very much. Bye.
Thank you.
Thank you.
Thank you.
Are we dialing in for session 2 now?
Yes.
Okay.